topic this morning, and it's lovely to see everybody, by the way. And if I haven't met you, thank you for joining. One thing I noticed in just sort of reading up and reviewing our wonderful trainings around health anxiety is there's a lot of verbiage, there's a lot of books. We have a really great book in the shared drive that's called Freedom from Health Anxiety. But I was I was trying to be conscious of calling this helping clients overcome health anxiety. There's a lot of like freedom from, let's overcome, let's conquer. So I just think kind of linguistically interesting, but yeah, figured I would start with a little comic there, but let's get into it. So I know it's the morning, and for many of you, we're starting our day, but let's start with a little brain teaser today. This is may or may not be a metaphor for health anxiety. So feel free to either raise your hand or put in the chat if you don't feel like chatting quite yet. Does anyone know the answer to this brain teaser? What gets bigger and bigger the more that you take away? I'll give you a moment. Alex, I like it. I mean, kind of true, yes. Not quite the answer to this brain teaser riddle, but I appreciate the humor and validity of that. Anyone else? Any thoughts? It's okay if you don't know. Oh yeah, Joey, what do you think?
Risking sounding like an idiot. Is it space?
Ooh, you could interpret it as that, yes. No, and you don't sound that way at all. Thank you for taking a risk. You're pretty darn close. I'll answer the question. So it's actually like a hole, right? So the more and more, I mean, again, in space works, I think too, for that, Joey, thanks for that. But fun metaphor for health anxiety, right? In the sense that sort of the deeper and deeper you're digging yourself into your health anxiety or your illness worries, kind of the larger your anxiety is. And so we'll talk about that a little bit more. I just thought that would be a nice way to prime our brains. Okay, so I wanted to share a sort of a sample, right? Because you'll see as we get into it, you know, sometimes there's not a ton of, I would say, extensive like outcome measures or assessments specifically for health anxiety. I think we have a solid working amount, and it's nice. We definitely have a great array in therapy notes. But it's nice to have a symptom checklist or something like this. And as you're looking at this, I'm also kind of curious, like, I think a lot of us probably could relate to some of these worries, right? Or maybe we have our own lived experience with them, or we've definitely heard it from clients. So kind of just looking at that, I mean, I frequently worry about my health, often seek reassurance, often check symptoms. This is just kind of a sampling from one of the books that I'll get into a little bit later. And I think the thing that can set health anxiety apart kind of around these common health worry experiences is the intensity of the feelings, right? How chronic the feelings are, and then really how much they impact your ability to function. So, you know, the other thing I think is worth noting is, so like, I think it was only in 2013 that we changed in the DSM. There was a former diagnosis of like hypochondriasis, right? And then that was kind of deemed, obviously, you know, there's maybe a negative connotation, maybe there's a bit of a stigma to it. So we shifted over into kind of the two primary diagnoses that I'll get into shortly. And I was just also thinking about how kind of, and I want you all to bear in mind as we're going through this content, like the human experience of worrying about our own health or worrying about someone else's health or wanting to be healthy is certainly, you know, I would argue pretty universal. And I don't know if anybody has seen, I was kind of thinking of two like recent-ish pop culture figures, if I can call them that, who I think in different ways kind of prey on one's fundamental potential health anxiety or the nuggets of it, right? Has anybody heard about or heard of this gentleman named Brian Johnson with this like Don't Die sort of campaign that he's doing? Okay, no, I'm seeing head shakes. Well, yeah, Miranda, you have. Yep. Okay, so yeah, exactly. Thank you. And a bit of snake oil. And then we also have just watched a documentary about a very interesting character, the Liver King. So are anybody familiar with that one? Very interesting individual. Two very different people, but their narratives are very similar, right? So for both of them, I believe, for the Liver King guy, it was about like, oh, my kids were really, really sick. They were not well until I, did this ancestral lifestyle, and it sort of cured them of their illnesses and their woes, and now they're thriving. And then Brian Johnson on the other side of the spectrum, he's kind of, I believe his narrative also kind of centers around being unwell or unhappy for much of his life. And then through, very extensive and costly measures, now his whole thing is, oh, look at me. Now I'm a paragon of health, and I'm aging in reverse, and you can do this too. So kind of, I think I mentioned those folks because I think anybody who may have health anxiety or may develop health anxiety, I kind of see that being preyed upon a little bit maybe, or being, perhaps taken advantage of, through folks like that, because again, it's kind of this fundamental nugget of a worry, I would argue. All right, so moving right along. So let's talk about kind of the two diagnoses. I know there's a lot of content on this slide. Oh, Jessica, yes, that's another great example. Yeah, I'd be curious. I was gonna say, I'm sure we can think of many, many, many other examples, certainly in this day and age of influencers, and it's interesting times. So yeah, I like that you're looking at it through that lens. So basically what we have are somatic symptom disorder and illness anxiety disorder. And again, this change, about a little over 10 years ago, right? 2013. You don't have to sort of know all of the content here. But what I do want to point out is just kind of looking at, some similarities and some differences between the two. For me, I think the biggest things to note are, well, for one thing, I mean, we don't fully know an accurate sort of prevalence of how many people are formally affected by or diagnosed with these. But some stats that I got, so prevalence of somatic symptom disorder, or SSD, I may call it, estimated like 5 to 7% of the adult population. I would argue that is perhaps a bit low. And then similarly, illness anxiety disorder, somewhere between, like my stats were around maybe 2 to 10% of the adult population, so not entirely accurate. But things to pay attention to, I think, in your clinical work, and as you're seeing these kinds of presentations come up, is just, the somatic symptom disorder is a lot about sort of like what's showing up in my body. I think something's happening in my body. I'm not sure, right? And then the illness anxiety disorder is a lot about this heightened anxiety and preoccupation with thoughts about potential health issues, potential, serious chronic illnesses, right? So they have certainly similarities, but some differences as well. And I think it's also worth noting for the illness anxiety disorder, what we tend to see, I kind of put an asterisk down there, of care seeking type versus care avoidant type tend to fall under one or the other category, meaning like, okay, I'm so scared that my doctor is going to give me bad news, so I'll just never go to the doctor, right? Like I'll just give in to that worry. Or I think this was something we saw a lot more, maybe 5 years ago or so. I want to monitor my temperature, so I'm gonna check my temperature every day, and if it's a hair above, decimal point above, whatever, 98.6, I'm going to the doctor. I'm calling my doctor right away. So we kind of can see it manifest in one or the other. I'm going to pause for a moment though. Does anybody notice any kind of key similarities or differences between the two? I'd say they fell obviously under the same umbrella, but anything stand out to you as we wake up? It's okay if not. Duration of symptoms. Yeah. Excellent point, Miranda. Yep. Mm-hmm. I'm glad you called that out. So kind of paying attention.
Oh, I'm
Mhm.
sorry.
Yeah, go
Um,
ahead.
for somatic symptom disorder, you normally have like at least a moderate, like actual somatic symptom, you're actually concerned about that symptom you may actually experience. And generally, illness anxiety is more about anxiety about acquiring or, yeah, or actually, I think you even have it, yeah, having or acquiring. Yeah, written down there.
Yeah, really well said. Thank you so much. Awesome. All right. Well, we will keep plugging away. So I want to talk about also, when we see clients here, I think a lot of times they might first come to us and they're not, it may not necessarily be specific to health anxiety, right? They might have something else going on, and then we might see health anxiety as having some comorbidity. So I did want to call out that comorbidity with common conditions that we treat, certainly generalized anxiety disorder, panic, OCD, major depressive disorder. It can hang with some of the personality disorders as well. And this isn't an exhaustive or an extensive list. I will say you will likely get clients that come in with the specific of like, I really want to work on health anxiety. I've had a couple clients I've worked with here who actually I had an interesting one. It was like truly health anxiety, whatever kind of diagnosis we want to put him in. And he'd had a very specific triggering event that was kind of causing him to believe he was having like severe vision blurriness and issues, and it kind of escalated. And, there were other things around it, but you may see sort of people like that. And those people are great because it's like, they come in, they're really goal oriented. They're very motivated. And I mean, he was doing really well. And I think we like got everything done within 4 to 6 months, like where he was ready to graduate and feeling really good. And I had recommended our Freedom from Health Anxiety book, and he really took to that. He was very resource driven. So you may come across that too. Some relevant clinical background or history. This isn't, exhaustive, but I would say just kind of keeping in mind that there can be a predisposition based on family history, genetics. Thought it was interesting. We sort of see the conscientiousness or, I don't know if, like, forgive the term, but maybe a little more neurotic, like personality types may give way to some kind of health anxiety. Of course, also risk factors, acute stress from trauma, specific triggers, accident, injury, prolonged period of being physically ill, maybe you've been caring for an ill loved one. That can certainly make one more hyper aware of their own health concerns or exacerbate what could lead to, SSD or IAD. So things to sort of note as you're reading, maybe you get a new intake and you're reading something like that on the history form, just kind of keeping your eyes and ears perked for those kinds of things. And then in terms of just recommended outcome measures, so did want to mention, we have a really nice set, I would say, in terms of what might help for diagnostic purposes or for working with someone through health anxiety. I kind of separated this into, a first session if it's a transfer, or maybe it's their intake, or on an ongoing basis. I do think that the ACE questionnaire that looks into trauma, might inform where you go with someone in working with health anxiety matters. There's also the patient health questionnaire. This is different. So it's just the PHQ. It's not the PHQ-9. I know we use that a fair amount as well. This one is more geared towards kind of health all around. And then I did also put links in here because if ever I can find, free fillable assessment measures, I want to share those. There are 2 versions of this health anxiety inventory. One is nice and relatively short and sweet. That's the short health anxiety inventory, or the HAI-18. That's about 18 questions. And then the other one is just the full version of that, which I think is somewhere around between 30 to 40. So a couple options for you. I will say too, one thing that's very handy is, these are some outcome measures you can also use. I think people with health anxiety tend to respond really well to checklists, right? So there's one in maybe the first chapter or so of the Freedom from Health Anxiety book that I mentioned. I'm also going to be referencing this little handy health anxiety workbook, which was written by a wonderful LMFT. And they have one in here as well in the beginning, which is kind of nice. Actually, that checklist from the beginning was that. So sometimes just a nice checklist, but some other assessments that you can utilize. Righty. Any questions or anything so far? Have I missed any chats? Okay. Awesome. Y'all are lovely. Okay. So one thing I do think is kind of helpful that I've really taken to for health anxiety is this thinking about it kind of as we would when we're working with people with OCD in terms of like this whole triggers, obsessions, and compulsions, thought cycle or process, if you will. So, I mean, I should say, like, technically health anxiety is not under the obsessive compulsive and related disorders class, right? It falls under the somatic symptom and related disorders. But many anxiety specialists, kind of myself included, would argue that health anxiety and its variations sort of represent like a sub-theme of OC concerns. And we can see that kind of looking at it and thinking about it this way is really helpful. So triggers can be anything, right? Could be anything. It could be what we were talking about earlier. You see, I mean, basically my thing right now is like, close your eyes, spin around, and pick a thing. Like, you can see a scary thing, right? You see a scary photo on social media. You hear a sad story about someone, with a serious chronic illness. You see a scary photo. You see a dead bird in the street. I mean, it could literally be, it's very, very broad. And then reminding, so I was talking about a lot of external cues. There could also be those kinds of internal cues. The example that I often give that I feel like is quite relatable is if you've ever had that situation where I don't know, maybe you were in a building or you were in a field where you knew there was some kind of a bug, right, that like crawls up on your ankles and it like itches you. And then you sort of leave with that phantom itch of like, wait, do I have bug bites on my ankles? Could be that kind of a feeling as well. And then we see some common obsessions and fears with health anxiety. So the fear of having a food allergy, fear of dying in childbirth, either person giving birth or, yeah, thank you, Michelle. Absolutely. That is, I could completely understand why that would come up in hospice. Fear of, a severe brain issue, brain aneurysm, brain tumor, seizure, stroke, anything like that. A lot of people also have that fear, that worry of not waking up or like dying in my sleep. So just some common ones that you might see. And it sounds like it's great that a lot of you have experience, perhaps with seeing how these themes show up. Compulsions, rituals, or safety behaviors, right? So these could be mental or behavioral. Like we said, avoiding medical appointments, repeatedly checking your body for signs of illness. It's interesting. I had one come up about like sort of the feeling, like if you've ever sort of, I think my like nodes are swollen, but I'm not sure. And then it's like, well, then what does a normal lymph node feel like? And then, or thyroid feel like, and then searching. So that kind of a thing. Frequently searching the internet, we call it like Dr. Google or a WebMD hole, to go back to the whole brain teaser. It can look like scanning for exits in various public places because you're sort of trying to plan and anticipate if a medical emergency were to occur, like where would you go? And so I gave this example here in blue just because I thought sometimes it helps to have a hard and fast example. Kind of goes back to the blurred vision one that I mentioned earlier. I think you might hear that one come up a lot, sort of sensory, are my senses playing tricks on me kind of a mentality. And, of course, in this day and age, like vision issues and blurred vision are not entirely rare because we're in a very screen centric society. So blurred vision when reading, when driving at night or staring at a computer screen too long is the example that I gave. So that would be the trigger or a set of triggers, obsessions or fears. fearing that the blurred vision indicates a serious neurological disorder. And then this person's ritual would be, well, they had two, right? So they would ask their wife to drive in the evening and sit in the back of the car. Or they would try to mentally predict how long they could sit at their computer before they've done irreversible damage to their brain. Sometimes maybe even like setting a timer, right? And then that would be, again, going back to what that may really impact their functioning. Perhaps they have a job where they need to be on their computer, or maybe they need to drive at night for whatever reason. So keeping that in mind too, like how does this impact one's functioning? So the two notorious groups that we see in health anxiety, I would say, are the body symptom monitoring and also reassurance, I should say. Obviously, you can kind of live in both camps, but it's a great, like, when we think about reassurance seeking, I mean, certainly we see that showing up a lot in all kinds of anxiety and in other things that we treat here. I always like to go back to, okay, are we looking for the reassurance? Are we looking for information? So are you seeking the truth, or are you seeking a desired answer? We can't, guarantee certainty as much as, and we can't guarantee perfect health. But we can try to live our life as best we can and be as healthy as we can and accept, that there's some uncertainty there. The reassurance group is typically centered around that core fear around one's health, or again, one's mortality, perhaps. And they're looking for reassurance around their concerns, right, rather than their health. So they're looking for, I need you to tell me that I don't have this thing, as opposed to like, just, what could look different. The body symptom monitoring shows up in a lot of different ways. Again, can be both behavioral and mental. It's a hypervigilance toward body parts and body scanning, and it's a hyper awareness of physical sensations as well. So it's that, like, it makes me kind of think of, for those of you that have started to dip your toes into like the ICBT, like the obsessional doubt sequence stuff. It's very like, wait, but well, what if my like leg is numb? Wait, I think my leg's numb. I'm going to go down that path, right? So it's kind of like giving into a nugget of a doubt about a potential, somatic symptom, snowballs and escalates. Okay, so what do we do? How do we treat it? How is it different or the same, right, than other things that we treat? I would say similarities and maybe some like nuanced things you might do a little bit differently if you do get a client that presents with health anxiety. So psychoeducation is always helpful. I would say just being mindful, when you're giving psychoeducation, that you're not that you're trying to share things that are going to be helpful rather than maybe exacerbate like fears or worries. I think there's like a way to do that, of just sort of as you're building the relationship with the client, like, hey, is it okay if we talk about, your brain? Like, is that, or are you worried about your brain? Should we talk about it in a different way? Just sort of like asking for permission, right, rather than forgiveness. A lot of the core CBT skills that we use, I think are very, very helpful. Oh, I think we have a question. Or no, maybe Susan, are you responding?
The way I see it is illness anxiety is for a delusional belief that you have something like cancer, for example, and you don't actually have any symptoms. You don't feel any particular way. It's just this absolute crazy delusional belief that you have it. I saw somebody like this who really believed he was going to die at any minute, and he went to many, many doctors, and it's not intrusive thoughts. It's a belief that he's not being heard, that he's really going to die at any minute, and he's to the point of being suicidal and really even getting violent with people because he's not being heard. Whereas OCD is somebody having ego dystonic intrusive thoughts about their health, something that they don't really want to have. They don't want to experience this. And then, so somatic symptoms would be you're having like what you would see in a emetophobia with somebody thinking that they could be sick and being confused about having nausea, or with somebody with chronic pain, and having their pain is no longer there because they've healed. However, the pain, like where the pain is being received in the brain has changed, right? It used to be like in the amygdala, but now it's like in this area, I think. And they're having those repetitive somatic symptoms.
Yep. Beautifully said. Thank you so much. Yeah. Totally. No, thank you so much. I hopefully that's helpful. I think it's also kind of like it's okay to not know right away how to differentiate, and maybe as you're working more with somebody, you might start to hear those trends and themes, like Susan, it sounds like you did with that client for sure. I think I recall you working with them. To that point too, I guess I would say like it's not necessarily through all these strategies, I would say it's like help the clients recognize that like the triggers, be they somatic or be they, scary thoughts about an illness, are neutral, but the story that you're creating about them, or the story that's developing about them, is not, right? So that's why kind of everything that I have read about it talks a lot about thought diffusion that we use in ACT, like how do we externalize those thoughts? Health anxiety is a great opportunity, if it's appropriate with the person, to maybe be a little silly, maybe use some humor. I think there's a lot of studies that show that can really help kind of alleviate the seriousness of health worries, which are valid. But I, read a lot about like using silly voices, singing it out. I mean, if people are not into that, like, putting it in sort of funny or silly font, all that good stuff. Cognitive flexibility is really important too. So can you delay, redirect, or point out the difference between attention and awareness? Can you focus your attention on more values-based goals? And of course, mindfulness is always helpful, because what we see with health anxiety is it's either, it's a lot of either past ruminations or future-based fears, or what ifs about health. I like this concept too of probability versus possibility, right? So the thought that like probability is sort of our most educated guess based on math or statistics, and possibility is grounded in the anxiety of all the potential what ifs. So we have our little friend chilling with her fears. For ERP, so we're going to get into it, and we are going to case example here shortly that I'll talk to y'all about. But I do want to talk about ERP for health anxiety, and this also was in the two-part training. So interoceptive exposures can be quite effective for health anxiety. I think that's worth noting, because, and there's different ways you can do them, but if you think about sort of like, one example that I was reading about was, again, to go back to the vision worry of like, okay, well, maybe do you look at sort of something that kind of makes you dizzy and then spin around to sort of simulate that experience, right? You can start as you would actually for working with clients with OCD, with outlining and making a hierarchy of those health anxiety obsessions and feared consequences, and then start to create exposure opportunities. Always going at the client's own pace, always going slowly. So a couple of examples that I wanted to share. So if the obsession is getting any kind of a deadly disease, the feared consequence is obviously dying before you've lived a full life. Then the exposure could be something like maybe you watch a TV or a movie clip about dying young, or read a blog about someone's cancer journey or chronic illness journey. Another example I have here is a seizure, stroke, or a visual impairment. maybe that person's really worried about kind of endless medical procedures. And again, looking at spinning objects or using optical illusions to sort of start to feel the experience of your vision being off or being blurry. Okay, so for you all to try, and you can put it in the chat if you'd like. What sort of let's say a beginning level exposure might you propose for a client that has an obsession about having ALS or MS perhaps, and then the feared consequence would be being maybe immobilized? Where might you start? Give you a moment to call it out or put it in the chat, whatever you like. Yeah, Miranda, go for it.
I was thinking maybe to start like watching a video of somebody in a wheelchair talk about like their experience of getting ALS or MS and like having had full mobility and then how they became immobilized.
I like that.
possibly.
Yeah, I like that. There's like a nice sort of progression there. And, as you would in any kind of exposure work, you would work through it with the client. But no, that's great. Oh, I'm seeing some others in the chat. Thank you so much. Oh, practice with a crutch or other walking device and then get their suds. Love that. Reading an article, absolutely. Or watching Grey's Anatomy clip. Yeah. Oh, holding an ice cube. I love that. Thanks, Alexis. Look at pictures of people in wheelchairs for sure. Would reviewing core fear be helpful too? Hey, oh, as in like before you get into the exposure work? Yeah, I think
Yeah.
so.
Okay. I wonder if that could help dictate like the exposure hierarchy of like, let's start somewhere small then.
Thank you. Yeah, I like that you are thinking about it. It's sort of like a more practical sense. I just wanted to get, but absolutely, yeah, you would go back to that and be like, okay, so how do we build off that specific core fear? Because maybe it's not being immobilized. Maybe it's like, a lot of people I know have a fear about being like burdensome, right, on loved ones or feeling like a burden, maybe. As an example, yeah. Lauren, a worst case scenario or watch a video. Oh, Danielle, I love it. An imaginal one. Thank you. Yeah, these are all great. Oh, thanks, Anna. Yeah. Y'all have great ideas for exposures. I appreciate that. So now it's going to be your turn. So have a quick case example and role play that I'll share with you. And then I have a few questions on it. That hopefully will be pretty short and sweet, but just to share with you. So let's say you have a 48-year-old client that we'll call Ben. A little bit of background on him. So lives with wife, 2 young sons, typically enjoys being very outdoorsy and active, right? Hiking, playing sports with his kids in the backyard. Recently, he's become a lot more irritable. He's feeling really emotionally distant. He's not as interested in socializing or playing with his kids, which used to be pretty big part of his life and something that really made his life, fun and joyful. Noteworthy history for him. So, he's 48. Over the past 3 years, 2 of his friends from college have sadly had heart attacks, and one of them did die suddenly from the heart attack. So when he was grieving that friend, he became very preoccupied and worried that, he would meet that same fate. So when he comes to us, he's doing a lot of, and this is what he would have put on, kind of his intake paperwork, his history form, a lot of scanning his body for signs of illness. He's not exercising at all, and hasn't been for several months. And again, as I mentioned, that used to be a big part of his life. He has a smartwatch and he's monitoring his heart rate multiple times a day. If he sees any kind of slight increase or jump, he starts to feel panic-like sensations or panic sensations of that chest tightness, that shortness of breath. And then that sort of somatic episode leads him to feeling anxious for many, many days. And he's contacting his doctor repeatedly after that. And that's happening a lot. So that's Ben. So now, does anyone need to look at it for another moment? I went kind of quickly. Just wanted to give you a little vignette though. Okay, cool. So we're just going to go question by question here. Which outcome measure or measures might you complete with Ben initially?
So I wonder, even Susanna, for this one, sorry to turn my camera off. Do you, I want you guys all to maybe do some breakout groups today. So I want you to come up with these on your own. And then I'm going to break you guys up and then we're going to come back and talk about them. So,
Okay.
Susanna,
I have a couple
okay
more.
with that. So, is that okay? So
Yeah.
just asking this question. So kind of write down, you guys, somewhere what you think it would be. And then, if you're okay with that, Susanna, we haven't
No,
done a breakout group in a
that would
while.
be
and we
great.
have
I
a
wasn't
larger group
sure.
here, so I would love. Yeah, no, this
Yeah.
is great. I appreciate. So everyone have an idea of outcome measures. You don't need to reply here. Just write it down yourselves, and you're going to share with the person that you meet with in just a minute. Kind of, you guys can debrief. And question
Thanks, Lisa.
2.
There's only 4 questions, I promise.
Great. No, this is great. I'm so glad we have time.
Me too.
What would you note as obsessions, fear? So you guys can just write that down. I'm going to give you a few minutes, just mindfulness. And then number 3, Susanna.
Is he engaging in reassurance seeking, body checking? Is it both? And then if you have time, would love to hear some examples.
That's
an
great. Even if
exposure.
you guys want to take a screenshot of those 4 questions before I put you into groups.
I'm just going to skip ahead for the sake of time for the resources page in case anybody wants to take a peek at it.
These are
Ooh,
so
I'm
great.
Yeah. One thing I'll say too about health anxiety exposures is it's always good to think of, as we do with many exposures, like thinking of one that you would do yourself as well, or that you would consider doing with a client, right? So like, I mean, if I was wearing the right shoes, I'd run up the stairs with somebody. I'd hyperventilate. Jumping jacks, that maybe, I don't know, it might be hard to do in a skirt, but yeah. No, I'm kidding. I would do jumping jacks. Nice. Ooh, drinking coffee. Yeah, like chugging coffee. Mhm.
Miranda, I want to make sure before our time runs out here, if you had a question or just a comment that you're welcome to share.
No, please, yeah.
Yeah, I know people have to hop off. I just don't have an 11. I had a question about like creating hierarchies and exposures that came up in our breakout room of like, so the first part is the exposure to like raising his heart rate, and then the piece of like checking or body scanning, that part which is the like seems to be the response. Is that like too much all at once to say like, okay, you raise your heart rate and then you're not allowed to check? Or is that something you more like collaborate on the client with about what they feel is like kind of possible in their wheelhouse to start with, and then kind of going from there and expanding the hierarchy and the like response prevention as you go?
I would say the latter part for sure of what you said. I would build as you go. Like the example that I had with someone was, and yeah, feel free to hop off anyone if you need to, but thank you so much for having me. You know, someone that was a teacher during the height of COVID, right? 2021, 2020, et cetera. And we went from needing to check my temperature on a daily basis, like take it and see it, right? Like we started there, and then we said, okay, could we do that instead of every day? How about every other day? How about then just the once a week? And then it was, what if you take the temp, what if you take it physically, but you don't look at the number, right? So you're gradually going. So like, I think the same would be true with a heart concern. I think you would slowly build and be kind of cautious about it. But you know, for exposures to work, you do need them to feel a little bit of that sensation that they're trying to avoid. So in that example, that's probably what I would do is build it as you would, you know, kind of using that ladder metaphor that we so often do. I think is a great one. Yeah. Any other questions or comments while I have you all? I know we're winding down. Thank you so much for having me. It was lovely to see you and some of you to meet. Always happy to be a resource if you need anything or talk through cases. Happy to help and hope everybody has a great day.